Thank you for joining us today. We're going to be giving you a presentation on protecting patient information in an electronic environment. I'm going to be discussing some of the new HIPAA requirements. My name is Holly Ahrens. I'm the Clinical Program Manager at HealthPoint at Dakota State University. We are the state's regional extension center, and our mission is to assist providers in adopting electronic health records and optimizing that use to demonstrate meaningful use. Thank you for joining us today. Today we're going to be talking about one central concept, and it may be something that you would not have thought of in terms of HIPAA or regulations, but it's the word trust. And I think all of us know that the patient and provider relationship is built on trust. The HIPAA regulations at their core continue to validate that relationship and build upon that trust relationship. What HIPAA requires is that providers demonstrate that their practices in making sure that the confidentiality, the integrity, and the availability of protected health information is kept private and secure. So really it is demonstrating trust, demonstrating compliance demonstrates trust. So keep that word in the back of your mind as we go through all these regulations. Our objective today really is to give you an overview of just some HIPAA basics, identify the omnibus changes, learn ways to operationalize or give you some tips on how to implement the administrative, physical, and technical safeguards, and then understanding as a person that works in healthcare what your individual responsibilities are. Ultimately, trying to create a culture of compliance. HIPAA, which is the Health Insurance Portability and Accountability Act of 1996, actually has several parts to it, but two main parts of it are the accountability and portability portions. We're going to be looking at only the two sets of rules, the privacy rules and the security rules today. So just some 101. The Health Insurance Portability and Accountability Act, otherwise known as HIPAA, was enacted in 1996. The ultimate goal, as stated in the regulations, is to improve efficiency and effectiveness of healthcare systems by standardizing the electronic exchange of administrative and financial data. Now, the two rules that we're talking about, the privacy rule was effective April of 2003, and then the security rule was effective 2005 in April as well. Now, we've had some new changes with the HITECH Act. There was the HIPAA Omnibus rules and some important dates that you should know. They were published in the Federal Register in January of 2013. The effective date was March of 2013, and we should have been compliant September 23rd of 2013. There was a transition period for business associated contracts that needed to transition in September of 2014 was the effective date for those to be in compliance. So those dates have passed, but we need to make sure that we are compliant, and a review of the rules is very important on a regular basis so we understand what we should be doing. Now, the omnibus components that we're going to be talking about today, the things that were affected by the HIPAA Omnibus rule are under privacy and security, your business associate, and the agreements, marketing and fundraising, sale PHI, right to request restrictions by the patient, electronic access, HIPAA breach notification, HIPAA enforcement, genome and privacy, and then other statutory modifications to research, notice of privacy practices, decedents, and student immunizations. Now, I want you to understand, with these two sets of rules, we really couldn't have one without the other. Privacy is all about control and the way that people interact with the and use the information. Security is all about protecting the information while we are doing those things. The privacy rules apply to, and their scope is all PHI, regardless of format, and the security rules only pertain to electronic PHI. Well, let's talk about what electronic PHI is, because sometimes there is some confusion about what that is. This is any PHI that is created, received, maintained, or transmitted electronically Now that could be where you are accessing it from your mobile phone or mobile device, where you have placed it on a thumb drive and transporting from one place to another. If it's on your hard drive, it's used it through a network. If it's on a CD or some other format, it has now become electronic. So who must comply with these rules? I think most of us are aware if we are or are not a covered entity, but now the compliance with the rules, with the changes with the HIPAA Omnibus rules, that business associates are now as liable as covered entities as are subcontractors of business associates who use PHI in the work that they do. Here's the list of electronic transactions that pertain to being a covered entity. There's much more information out on the ocr.gov website to give you an indication about if you are or are not a covered entity. So what are your responsibilities? At the practice level, you are required to have policies and procedures that address the privacy and security rule obligations. At the individual level, as staff members, we are all required to carry out those established policies. So let's dig in. For the privacy rule, the purpose of the privacy rule is to restrict unwarranted disclosures of PHI, give individual greater control over access, enable proprietors to use information to make decisions and fulfill obligations. So these are the three things that are the true purpose. So restricting unwanted, giving the patient or the individual greater control over access, and then allowing providers to use and exchange that information to fulfill obligations and to make decisions and to provide treatment. I think there was a big misconception about what the privacy rule was supposed to do, but I would love for everyone to retrain and think that these are the true purposes and not strictly to lock down information and no sharing. So the scope is identifiable information, information that describes any individual's health status and services that were provided and their demographics. And again, the scope applies to all PHI regardless of format. Let's talk about the rights of the patient. In the privacy rule, there was rights given to the patient to empower them because one of the purposes was to give them greater access to, control over access to their health information. So they have the right to access, right to amend information, the right to accounting of disclosures of their information, the notice of privacy practices of the healthcare provider or the covered entity, and the right to agree or object to the information that is in the record, and the right to request a restriction. So these are the 6 rights that patients have that were part of HIPAA. There is a change in the right to access. The new rule shows that we should be giving access in electronic format if requested. Now, you have to make sure that this format is readily available, and the way that you do that is we're going to give you some tips on how to do that. Providing in another readable electronic form that you can give that to the patient. And if you are giving access, you can make an allowance or a denial furnished within 30 days versus 60 days, which the previous rule had stated. So how do we do this? How do we operationalize this in terms of these changes? Really identify the ready available formats in your practice. So you don't have to have a limitless types of formats that you will give people electronic access. If you have a patient portal, that is a great way to give people access. If you don't have a portal and you have an abundance of thumb drives that for some reason you have on hand, maybe that is your ready available format. So whatever you put into your policies and your notification of privacy practices to your patient, you identify the available formats, and those are the ways that they can ask to get that information. So obviously you're going to have to create a workflow of how you flag those individual requests that are electronic requests or to access an electronic format, and identifying that person who's going to be responsible for that. Another new rule in terms of patients' rights, request a restriction of uses. The individual can now request a restriction on disclosing information And the covered entity must agree to this. And this is a request of restriction to a health plan, which is like insurance companies, for the purpose of carrying out payment or healthcare operations if this restriction applies to PHI that pertains solely to a healthcare item or service for which the provider of services has been paid in full out of pocket. Okay, so let's just break this down a little bit. This is all about when a patient comes in and they have a service done or they buy equipment from you and they pay cash for it. And it's only for the things that are paid in full in cash or, or check, credit card. Anything's paid in full right then and there at the time of service. They can request a restriction. It has to be a formal written request that you not disclose the information about that particular service or equipment to their insurance company. Okay, so this, obviously I know everyone's thinking, okay, this is going to create problems if we do a full visit and they just pay for, let's say, a spirometer. And that is they're buying the spirometer from us and that's what they're paying for. Well, let's think about this. So how do we put this into practice? One thing you don't want to do is create separate records. You want to make sure that you keep the records together, but you're going to have to employ some type of flagging system when you receive one of these formal requests to restrict information based on this new rule. Now, as we know, when we bill for things are bundled together in terms of coding and services. So if you can unbundle the services and not cause greater charges to the patient, you should try to do that. Now, if that's not possible, make sure that you educate the patient that by unbundling services that they may be charged more for certain things, okay? Now, this request that they put in does not apply to follow-up visits, either for you or for any referral that you make based on the visit that you had that they asked the restriction from. And again, no downstream providers. Anytime the patient wants to make a restriction based on paying in cash or paying full for product or services, they are responsible for each time to make that restriction request. All right, so let's look at some of the other elements of the privacy rule that may have been affected by the Omnibus rules, but some of these I'm just going to bring them up because I think we need to have a refresher about these things. So some of these I will stop and give you some more detail. So these are the elements that you should have in policy: maintaining and updating your policy and procedure manual, designating a responsible person for privacy and security responsibilities, duties, tasks, you delineating those responsibilities and their authority, training. I think some of us have gotten into a habit of just rolling out a one universal training, but it really should be role-based. So if you have reception area, if you have cleaning staff, if you have providers, and you have billing people, all of them within their roles that you have defined have different types of access to PHI, and their training should reflect the type of access they have. So if you have a CEO that never goes into the electronic record or is never in patient records, has no interaction with patients, their training could go with just basic HIPAA training. But if you have providers and nurses, any healthcare providers who have full access, their training is going to be very extensive, and it should be based on their roles. And then the next policy and procedure you should have is about compliance and sanctions. Compliance should be tiered, and showing and sanctions also should reflect the tiers of types of uses and disclosures or breaches. So if there was an unintentional breach, if there was an intentional breach or a technical breach, you would show sanctions that are tiered and leveled on those different types of disclosures. All right, continuing on. There is reporting and investigation documenting of violations requirements, use and disclosure of information in all situations. You should have a full, this should be a very large, a few pages at least, of situations of how you would use and disclose information. So for treatment, payment, and operations, you would define for your staff how they would handle uses and disclosures. For law enforcement, if something is authorized by the patient, and anything that's required by law. So those scenarios or situations must be described in full in your policy and procedures. You should have an element or a policy of access, restrictions, and amendments. That's all about those patients' rights. Your notice of privacy practices. We're going to talk about this because there was some changes there. The authorization to release information, your accounting for disclosures, minimum necessary, what is necessary to do your job, any fees that are applied for providing records upon request. We're going to talk a little bit about that because there's been some changes there. And then business associates will have some discussion there as well. So let's talk about the notice of privacy practices. This is a formal notice to patients who you have a direct treatment relationship with, and it is provided to them at their first interaction with you, first appointment or encounter. And this should have been in place in 2003 when we all had to create these notice of privacy practices, post them in visible areas within your waiting rooms for your patients. There has been changes in the HIPAA Omnibus rules to amend that form in the areas of breach notification, disclosure to health plans, marketing, sale of PHI, and fundraising, and how to opt out. So you should have a new notice of privacy practices that was in place September of last year, 2013, and all of your patients that come to you from that date forward would need to be provided access to this notice of privacy practices and then sign that they have been informed. So to put this into practice, get the new template, provide that to patients, and move from that mindset that this is just an obligatory administrative burden type of thing, that using this as a marketing type of thing that says to your patients your dedication to their privacy and your security. And this also is compliance documentation in case of a HIPAA audit. So all of those patient records that either you are clicking to in your record, electronic record to say yes, they received it and a signature, or if it is a paper record, these are things that a HIPAA auditor would request to see that you've supplied that to them on that compliance date. All right, so let's talk about fees, a little bit of change there. HIPAA has always said that you can determine your reasonable fee, okay, and that you can take into account labor for copying, compiling, extracting, scanning, burning, whatever it is you need to do to collect that data, media costs and supplies as well. But you can no longer factor into that fee any retrieval fees, because since we have moved to an electronic record, so you shouldn't have the types of burden to collect or retrieve records like we did before, because I remember working in downtown Detroit at Henry Ford Hospital. We had some of our old records were located on the other side of town, so we had to get in, vans and drive over there, collect the data. So it took transportation costs, it took labor costs, those types of things. No longer can we do that because most all records are electronic and they can easily be retrieved. How do we put this into practice? Really identifying someone who's is responsible for this type of work and making sure that they understand the responsibilities. You should, in your leadership, be doing a cost analysis of what this typical data set request that you get, and this should be an auditable analysis. Always update your policies and your notice to patients of the prices, and make sure they know these prices at the time of their request. And then review that on an annual basis to make sure that you're not overcharging or undercharging. Okay, business associates. One of the major changes in the HIPAA Omnibus rules was about business associates. And business associates are people who work on behalf of covered entities, and they create, receive, maintain, or transmit PHI in the work that they do for a covered entity. The new rule now says that subcontractors that business associates may hire to help them do this work that also create, receive, maintain, or transmit PHI on behalf of the business associate is now responsible as well. So the rule states that now these people who act as business associates can also be health information organizations, e-prescribing gateways, or other persons that provide data transmission services. It could be a person who offers a personal health record. Your electronic health record is a vendor is a business associate. Now, business associates must comply with all of the technical, administrative, and physical safeguards that are required under the security rule, and they are now directly liable for violations. This is a wonderful addition because in the original HIPAA rules, the covered entity was liable for violations, even if they were done by the business associate. So this places accountability directly to the people who are dealing with PHI, and this is very important to ensure that people are accountable for their actions. So business associates must comply with any use or disclosure limitations that are in the contract. Please hear me say in the contract that you need to describe how they can use and disclose information within your contract that you have with the people. And also subcontractors as well, as business associates hire on, third-party subcontractors, that they would define also in their contracts how those uses and disclosures are done. Here's some examples of business associates. So it could be utilization review, a billing service, your legal department, accounting. If you hire a consultant for anything that would use PHI, your cloud hosting organizations, personal health record vendors. So how do we put into practice, again, identifying who's responsible for this type of work within your organization, who's responsible for contracting, writing those contracts, ensuring that they're kept up to date. Make sure you get that new template, review the functions, and change the language in those contracts, and make sure they're renewed by the deadline. Some more elements of the privacy rule. You should have policy and procedures about marketing and fundraising, sale of PHI, research, and decedents. There were some changes to all four of these. Let's talk about those now. For marketing and fundraising, this has always been an area that a lot of healthcare providers have kind of backed away from, but you should know that pharmaceutical companies and a lot of other companies, health-related products, they are offering more and more services to you, and you have to think about what exactly they're doing with PHI to ensure that you are covering yourself and notifying your patients of what may happen if you enter into a vendor type of relationship. And a great example, I think, is for like refill reminders. If you are working with a company that says, okay, we're selling a product, and one of the services that we'll give you is that we will have an electronic reminder system that could be sent to your patient, and that will remind them that, they have 10 days left in their medications. They should be refilling their medications. So that's a great type of example, because that type of communication, you don't need to notify the patient about that type of communication. But if you have health communications about health-related products that are being sent to the patients, or face-to-face type of marketing to the patients, to those individuals, you need to get an authorization if all of that is being paid by a third party. Okay, so you need to notify your patients about that, and you would get authorization from those patients to allow that health-related product company to contact those patients and do any type of marketing with them. Okay, fundraising, again, this is something that most people aren't involved in, but you have to be aware that covered entities can use additional information to target fundraising communications but you have to provide an easy way for people to opt out or to stop receiving those solicitations. So sometimes on a patient portal, there will be a field that says, we participate in fundraising activities. Would you like to be involved in or have your information used in fundraising activities? And it can be as easy as yes or no. And they would click that button, and then those records then would be not allowed to be taken out for fundraising activities. Okay, sale of PHI. Now, even when disclosure is permitted, the covered entity is prohibited from disclosing PHI without individual authorization if they are receiving any remuneration. So this is something that is something that Medicare CMS really looks at, making sure that we are not selling PHI and getting any type of payment, and it doesn't have to be just financial. It could be directly to you, and it's not just financial things. So make sure that if you are selling PHI, and this may be that you're selling PHI to a company for them to do any type of business process such as marketing or to do some type of research, anything like that, you must get prior authorization from each individual. Okay, the exceptions for this are if you, let's say you sold your business, your healthcare practice, you would not have to get authorization from each one of your patients because records are part of the sale. Public health requirements, you wouldn't have to do it for that. Research, sometimes you will be selling PHI, but if remuneration is limited to the cost to prepare and transmit that PHI only. Okay, let's talk about research. And research has always been one of those areas that people get somewhat confused. But during research, researchers notify patients, they're required to notify them of all the potential things that could possibly go wrong. And sometimes those authorizations that they fill out, are just one authorization for one event or one process or one study. Now, these are permitted for use and disclosure of PHI for conditional or unconditional research activities. Now, they must have clear opt-out for voluntary opting out for unconditioned components. Okay, so if you have an authorization where you're saying to the patient that on these conditions you'll participate in the research, and then these unconditional components of the authorization, you have to make sure that they can clearly opt out for the unconditional types of things. Okay. Future use authorizations, these are permitted as long as authorization for future research includes the adequate description of what is going to be done. Okay, let's talk about research. And research has always been one of those areas that people get somewhat confused. But during research, researchers notify patients, they're required to notify them of all the potential things that could possibly go wrong. And sometimes those authorizations that they fill out are just one authorization for one event or one process or one study. Now, these are permitted for use and disclosure of PHI for conditional or unconditional research activities. Now, they must have clear opt-out for voluntary opting out for unconditioned components. Okay, so if you have an authorization where you're saying to the patient that on these conditions you'll participate in the research, and then these unconditional components of the authorization, you have to make sure that they can clearly opt out for the unconditional types of things. Okay. Future use authorizations, these are permitted as long as authorization for future research includes the adequate description of what is going to be done. Okay, well, we've gotten through the privacy rule. Now we're going to move into the security rule. The purpose for the security rule was for covered entities to implement safeguards. Okay, the requirement is there to implement safeguards. And those safeguards are really to protect the confidentiality, integrity, and availability of electronic protected health information. The scope is just electronic PHI. The elements of the security rule is all about safeguards, and there are three types: administrative, physical, and technical. Let's look at the administrative safeguards first. There are four different categories. First is security management process, assigned security responsibility, workforce security, and information access management. First, let's talk about the security management process. Within that element, there is requirements for risk analysis, risk management, having a sanction policy, and how you will review your information system activities. So how do we put these four things into practice? First thing is to conduct a thorough and comprehensive security risk analysis. Some key elements about what a security risk analysis is it creates a PHI inventory, so all of those places where PHI is stored or maintained or created. You identify how critical those systems are to your day-to-day operations and what threats and vulnerabilities those systems have, and then that feeds into your risk management plan of how to mitigate those threats or that risk down to the lowest level, and then making sure that those that are the most critical are a disaster recovery or recovery plan is created to ensure that those systems are back up as soon as possible. Now also you're going to be identifying someone who's responsible for all this type of work, and also for reviewing audit logs. This may be on a daily, weekly, monthly basis, and also what flags within the system would be considered threat flags or intrusion flags. Next, information access management. Under that heading, there is isolating healthcare clearinghouse functions, access authorization, and establishment and modification. Also under administrative safeguards is security awareness and training. This is really your security training program, and it must have elements of how you're going to remind people about security issues on a regular basis, protection from malicious software, so some antivirus and how you implement that, password management, and then also login monitoring. So let's talk about password management. This is one area that I think all of us fall down on, and we need to implement in policy requirements for strong passwords, and this should be at least 8 characters, no recognizable words, so no kids' names, no puppy names, nothing like that. Should be a combination of letters and numbers with at least one uppercase and one special character. So these should also be changed routinely. We recommend quarterly. Don't ever share your passwords. Don't write them down. Change default passwords that come with software or applications or hardware immediately. And don't share any logins. This is one of the main no-nos of password management. Next elements in administrative safeguards are security incident procedures, contingency planning, evaluation, business associate contracts, and agreements. Under contingency planning, I think it's really important, as we talked about, as you identify those critical systems, you need to have a data backup plan, disaster recovery plan, emergency mode plan, and testing and revision procedures. How do we test all those plans and make sure that they work properly? And then that analysis, as I mentioned before, feeds these plans and how they should be implemented. Moving into physical safeguards, the elements under that are facility access controls, workstation use, workstation security, device and media controls. I'm going to touch on device and media controls because I think we are seeing more and more thumb drives, CDs, different formats of where we're putting data. And we need to ensure that we outline in policies the appropriate ways to dispose of those types of medias. And then also, if we can reuse them, what's the process to wipe data and then reuse them? Being accountable, who signs them out to make sure that they get back to us. And if there is any requirements for data backup and storage, that those are outlined in policy. So how do we put this into practice? If you are going to dispose of these types of things, you have to make sure that they are unusable and inaccessible. So whether it's hard drives that, if you're going to sell computers that you've used or give them away, that you understand and outline taking out hard drives, wiping them, or shredding them, or what is going to be the process that you will make them unusable and inaccessible. Is it a permanent delete? Is it a wipe? If you're going to reuse, accountability for all of the hardware and medias, that you make sure that someone is tracking where they're located, when they were placed there, and if they are then on a destruction list, that whoever takes them to be destroyed logs that information. So documentation is very important. And then your data backup and storage of these things, if that is something that you're going to do, making sure that they're exact copies and testing that they're exact copies and not just assuming. All right, one of the other areas that I think in terms of access that we need to discuss as we become a more mobile society, that remote access is something you are going to have to tackle in the next few years if it hasn't already been addressed in your practice. With all the mobile devices that are being brought to healthcare, we have to make sure that we have a policy on remote access. First thing I want you to do is just be cautious. Be that person who asks the questions. And in your process, you should have a formal process of how you give people remote access. So you would identify in policies what would warrant remote access. So let's say you have a mobile provider. That would be one thing that you would say, okay, we now have a provider that's traveling between 3 different locations and then does work at home also. So this would be a case where you would say, okay, mobile providers are a case that we will entertain and will review access. So review those cases, make sure you document why you're allowing that access, and then train the staff to understand the risks of remote access. That training should be evident in their personnel file as well. So when you are making a case for remote access, you're going to look at how, these are the areas that you'll review. How are they going to access it, the information on your system? Where is it going to be stored? Will you allow storage on mobile devices? Will you not allow storage? What is the transmission method? So all of those things need to be reviewed, and then a decision can be made to ensure that you can encrypt and you know that they're not going to store on mobile devices, those types of things. So that process should be documented very well. Moving into technical safeguards, the elements under here are access control, audit controls, integrity, person or entity authentication, and transmission security. First up, let's talk about access control and how you put it into practice. This is all about staff members and how they get into systems. So you're going to have to give them a unique user ID. You need to identify if there is emergency access needed, who is able to do that, and it's outlined in policy who and how you do it. You're going to have automatic log-off settings in your systems, and you're going to require encryption and decryption. Now, the encryption is an area that I think a lot of people have get kind of a glazed over look, that they don't understand it. It's too technical, but let me tell you, I can break this one down because this is the way I understand it. Someone explained it to me. Basically, you're putting your information in this safe, and once it goes in the safe, it basically stirs it all up so it is not readable anymore by humans. So what you need is you send a key to someone who's going to receive this information, and you say to them that this is the key that you can unlock the safe and then we'll decrypt this information. So you have to physically do, or not physically, but an action has to be done to encrypt it, which is making it unreadable, and then you give the intended person a key to decrypt. So how do we put this in practice? Okay, so working off of that PHI inventory, so you know where PHI is located and contained, you have to determine what type of data should I encrypt. Okay, if it's anywhere on computers or devices, those have to be encrypted. Okay, number one, laptops, encrypt them. Any emails that contain EPHI, those must be encrypted when they're being transported. Because what it is when you're sending an email that is unencrypted, it's like sending a postcard with patient information versus a sealed envelope. Okay, anyone can read it that might stop it in its transmission. All right, so EPHI that you transmit, so claims, those that need, however you're transmitting information, all backups, the devices need to be encrypted that they're placed on. And when you're accessing the internet, make sure it's a secure socket layer. And you'll notice when you go into the internet, there'll be HTTPS, and usually your address bar will turn green. You can know that this is a secure line. And then also data mapping, understanding how your data flows so you know where the risks are. So if there aren't firewalls or if there isn't encryption in transport, you know that you have to go ahead and start implementing some encryption processes. Okay, well, if we haven't gotten your head spinning already, we've got one more thing, breach notification. So there were some changes in the HIPAA Omnibus rules, and really this has become one of the larger portions of the changes, and it's all about breach notification and how we analyze breaches. So what is a breach? Let's do that first. It's an impermissible use or disclosure of unsecured PHI presumed to require notification. So I want to stop there. You'll notice already there are some qualifiers here. If it's unsecured, it's already presumed to require notification. So to me that says if I've secured it, that presumption now is not there. Okay, so keep that in mind. What was the potential that the PHI was actually acquired or viewed, and what extent to which the risk to the data has been mitigated? Okay, so this process of doing a risk assessment on a breach must be done now. So a breach notification of unsecured PHI, this notification would be to the affected individual, HHS and OCR, and in some cases you'll have to notify the media. Notification to the Secretary of HHS or OCR of smaller breaches can occur within 60 days of the end of the calendar year in which the breaches were discovered. You are not required if the covered entity can demonstrate that there was that low probability through your assessment. So let's talk about this assessment. How do we do this? This is a formal process, and it must be documented how and who is responsible to do this assessment in your policy. It applies to any limited data set that you deem to be disclosed. You must require to answer these questions within your assessment. Did it violate the privacy rule? Was PHI unsecured or unencrypted? Does it qualify as an exception, or in the rules there are 3 exceptions? And does it pose a significant financial, reputational, or other harm to the affected individual? And to get that to be, to identify what's significant, there is a rating tool that you must use. Best advice here is to just document the process that you go through to ensure that when you determine that you've mitigated this to the lowest risk possible and you don't have to notify OCR, you've got documentation to validate that. Okay, let's talk about enforcement. There was some changes in the Omnibus rules. They clarified the tiers, the lowest tier, intermediate tier, and highest tier. The lowest tier, you reasonably could not know of the breach. Those would fall into that category. Intermediate, you either knew or you should or would have known but did not act. And then highest, obviously, would be some willful neglect was evident. HHS was required to investigate and impose monetary penalties in willful neglect cases. So anything that falls into that highest tier, they're required to impose penalties. And what they can do is they can also provide information to other agencies for enforcement. So, such as the Attorney General's office in your state, they could notify them to then bring criminal charges against providers and provider offices and pharmacies and people who work at pharmacies and who work at provider offices and civil suits. So it doesn't just end at this enforcement at the OCR level. We now have 30 days to get these notifications in now, and that begins when the provider knew or should have known of the violation. Well, we've gone through quite a bit of information today, and I'm applauding your patience and applauding your perseverance to get through all of it. But we did accomplish our objectives today. We reviewed some basics of HIPAA. We reviewed the new Omnibus rule changes, gave you some tips on how to operationalize these things, and then showed you some understanding about what you're responsible to do at an individual level. Now, there is the opportunity now to really change the conversation. In 2003, when HIPAA became effective, I think that it was the mindset was more about we need to lock down information and not share with anyone. I think that we need to change some of that and now be looking at it again that this is about patient trust and that we want to ensure that our patients know that we value their protected health information. We're going to do all that we can to make sure it's private and secured. So security should not be taken lightly in your practice. Make sure that security risk assessments are a priority because they really are the backbone of HIPAA compliance. And let your patients know about what you're doing to make their information secure. I can tell you that patients, in terms of trust, when they see that you're doing all that you can to make sure their information is secure, and especially in this hacker type of environment that we live in on the internet, that you're doing everything that you can, that provides security on a level that I don't know that you may have seen before. So I think it's time to change that conversation because you really are working toward a culture of compliance. Well, I want to thank you again for your attention and your perseverance. The slide deck is available to you as well as the recording. Have a great day.